Oh no, an ankle sprain. Welcome to Didactics Online. We're going to go over the compensation after an ankle sprain as well as some of the treatments you can do for an ankle sprain. So the body's quite amazing. Even in a traumatic circumstance like an ankle sprain, there's a certain compensatory pattern that will sometimes show up in your patient. As the ankle most commonly inverts due to the mechanisms or the strength of the ligaments, you're going to have some stronger ligaments here on that medial side with the deltoid ligaments, not allowing it to evert, and a little bit weaker with the ATF, PTF, and CF ligaments here, allowing that inversion. So with an inverted ankle, the talus will internally rotate. The tibia will then externally rotate, leading to an internally rotated femur. Due to coupled motion, as the ankle inverts and plantar flex, the fibula will actually move posterior here at the more proximal end, while moving anterior at the more distal end. Moving on a little bit further up on the body, you're actually going to see a posterior rotated hip on that side of the sprain, as well as a forward torsion of the sacrum, again, towards that same side. So if you sprain your right ankle, you can expect a right posterior rotation with a right on right sacral torsion. Now to go over some of the treatments, we're gonna bring in our injured colleague, Megan O'Connor. So we're going to talk a little bit about the ankle. You can stay right here. So the first couple weeks, you're going to want to stay pretty indirect and soft with just myofascial work when it's in the acute phase. So the first couple weeks, you can do some BLT, some myofascial work, as well as some lymphatics all the way up in order to take care of that swelling. Of course, all the standard of care as well, you want to ice and make sure that you pay close attention to any x-rays or MRIs that are needed. So with the fibula, which we'll pay most attention to right now, the fibula runs on the lateral aspect of that lower extremity and has a head as well as this lateral malleolus. During an inversion, so as they invert and plantar flex, the posterior aspect will move, or the proximal aspect will move posterior, while the distal aspect moves anterior, kind of like a seesaw motion. In the exact opposite, so if we dorsiflex and evert, you will move posterior distal and anterior proximal. So for the first couple weeks when we're just staying very light, we're going to be doing some myofascial as well as some BLT. BLT is a whole other subject on its own, but basically it's going to be trying to balance this fibula head using both proximal and distal attachments and move it into its more physiologic location. So in this case, we'd be moving it from posterior to a little bit more neutral. As you get further along into the progression of the recovery, you can get a little bit more direct with some muscle energy or even some HVLA. So the big part with muscle energy of the fibula is incorporating that coupled motion here at the ankle. So if we have a fibula that is posterior, that means it's living in posterior inversion and plantar flexion. In order to take that into a direct treatment like muscle energy, we want to dorsiflex and evert while applying an anterior pressure to this fibula. So you get hooked behind that fibula head, apply anterior force, get it into that direct coupled motion, and ask your patient to just push on the gas pedal. She relaxes. Then we take up the slack and move even further. Push again, relax, and push even further. If we were going to be using HVLA, basically what you do is you create a fulcrum with your digits in your hand, and you want to use that fulcrum right behind that posterior proximal aspect in order to create that anterior motion. So again, using coupled motion here, dorsiflex and evert, fulcrum here, bring it to that barrier, and just a short HVLA thrust. Again, you're going to want to wait until a little bit later in an acute injury like this, but it's something you can use later on in the recovery or just for a normal non-traumatic injury in this area. So let's say that we had an anterior fibula head, and now we want to push it posterior. So using coupled motion again, we're putting posterior force on that proximal aspect, and with an anterior ankle, you guys know that we're living dorsiflexed and everted, so you got it right, we're just plantar flexing inverted. We're again pushing down here, pushing posterior here, and asking the patient to pull the foot up, and relax, taking to that next barrier, pull up, and relax, and taking to that next barrier. HVLA here, there's a few different holds you can use. Again, you're just using that coupled motion, and you're going to push down. A lot of times, people can just use that hypothenar evidence, push down here, take that coupled motion, and just a short thrust down. Again, it's just a short, non-traumatic thrust. You're not really trying to get any articulation here, just trying to push it back against that barrier. Thanks for joining us on Didactics Online. If you have any questions or comments, please post on the website.